we go. Look at that photo. All right. Good afternoon, everybody. Thank you all for being here, those in person and folks who are joining us online. I'm delighted to be here. I am always grateful for this opportunity to be able to share what I learn in my clinical practice with everybody. So thank you. So the topic for the day is dermatological manifestations of endocrinopathies, the skinny of it. I hope you all can hear me. Then Kelly's going to do a sound check there. Okay. All right. Okay, good.
I'm sorry, I went out.
Okay, perfect. All right. Okay. The skin, which is an endocrine organ by itself, is a window to a lot of internal pathological conditions. Most endocrine conditions, endocrine diseases, have some kind of skin manifestations associated with it. As such, being well-versed with the skin manifestations might help in early diagnosis and treatment and preventing future morbidity and mortality. Some skin conditions predate other clinical manifestations of the endocrinopathies. Some occur concurrently and might be assigned to looking for other endocrine conditions. And sometimes you can use your skin results or the skin manifestations as a marker of how good your treatment can be or treatment is. Some of these may resolve with appropriate treatment. We as endocrinologists are expected and known to be astute clinicians, so having this skill of excellent physical diagnostic abilities is great for our armamentarium. This topic today is going to focus mostly on recognizing these skin manifestations and correlating them with the endocrinopathies, so treatment is beyond the scope of today's topic. I have tried to be pretty comprehensive, and it's going to be a long lecture, but know that there are some conditions that may not be included in today's talk, but those are usually the rare ones. With all of that being said, let's get started. I have nothing to disclose. Let's start with some case presentations. A couple of these were what I had in my own clinical practice. So case one. Also, I wanted to mention that I will try to get these slides ahead of the explanation. So if you want to jog your memories from what you've read in the textbook or seen clinically, try to do that and come up with the diagnosis. Hoping this lecture helps hone everybody's physical examination skills. So a 27-year-old man presented to the ER with left-sided weakness, headaches for several months, and was diagnosed with invasive pituitary macroadenoma with prolactin levels that were really high at 7,000. He also had a prior history of primary hypothyroidism. He had been brought up by his maternal grandfather, and not much was known about his paternal history, except that his father was schizophrenic, died in his 20s. Maternal history was not concerning. His metabolic panel was normal with a calcium of 9.9, and physical examination revealed a morbidly obese individual with these findings. We're just going to go to each case, and we'll talk more later. Case two. This was a 60-year-old African-American man with a BMI just in the overweight category at 26, presented with type 2 history for about 20 years, diagnosed at age 40, with neuropathy, retinopathy, hypertension, and hyperlipidemia. He reported a femoral neck fracture at age 53 after a fall and osteoporosis on the DEXA. Family history included diabetes mellitus and obesity. Interestingly, his longtime barber reported having difficulty cutting his hair due to irregularities of the scalp. Exam revealed this. We also have imaging here. And we come to the last case before we go to the actual talk. A 45-year-old white woman, BMI of 48, presented for follow-up of primary hypothyroidism, type 2 diabetes, pretty well controlled, 5.6% A1C, dyslipidemia with a normal CMP. During the routine follow-up and physical exam, just a general regular exam, this was what I saw. What's the next test you would order? All right, I'm going to breeze through some of these slides. So this is a pretty typical presentation of angiofibroma. Polyglandular. Yes. This was actually my patient in my practice with both those manifestations. Lipoma. You see something here. Pretty subtle, but there. Gingival papule. And all of these are manifestations of MEN1. So cutaneous lesions are part of the diagnostic criteria for MEN1. 2 or more of these lesions are considered diagnostic, or 1 if there's a family history of MEN. Being well familiar with all of these lesions could actually help you with early diagnosis of these patients, and also help with screening some of their family members who might have the same condition. Angiofibromas are the most common with 88% prevalence, and as you can see here, they are telangiectatic, skin colored, or sometimes pinkish brownish papules, mostly located on the face. Can you see my arrow when I do that? You can? Okay. Polyglandular are slightly less frequent, but still 72% skin colored or slightly hypopigmented, dome-shaped, well-circumscribed, firm round to oval papules, and these are mostly present on the torso, like you saw in the earlier patient right around here. Lipomas are less common, about a third, and located on the trunk, extremities, and scalp. We might also see cafe-au-lait macules in about a third to about 40% of the patients. They're not diagnostically significant or specific for the MEN, but they're there. Confetti-like hypopigmented macules and gingival papules. What's this? This is actually cutaneous lichen amyloidosis. Multiple endocrine neoplasia type 2A is often associated with this skin manifestation. It is commonly located between the scapulae or on the extensor surface of extremities, and itching or pruritus is the often initial symptom, which is due to deposition of the amyloid material. This leads to scratching, damage to the keratinocytes, which degenerate and cause these thick, pigmented, scaly, papular lesions. This particular skin manifestation is usually associated with red codon mutation, and all of this is associated with the future onset of medullary thyroid cancer. So 35% of patients with this mutation have CLA in their lifetime, and it is a precocious marker, which means it presents earlier in the diagnosis and can actually foretell the likelihood of having medullary thyroid cancer in that particular individual or their families. What's this? So these are mucosal neuromas. Multiple endocrine neoplasia type 2B is commonly associated with mucosal neuromas, papules, and nodules. These often occur by the 5th year of life and are present in the lips, tongues, eyelids, and conjunctivae. On the lips, they can be diffuse, fleshy projection. They're usually present on the anterior third of the tongue and could be clear to pink papules. Eyelids might be involved, and you might see them lined on the edges of the eyelid. Conjunctival involvement may also be present, and you might see disorganized eyelashes because of the presence of these conjunctival papules. They also may present, multiple endocrine neoplasia type 2B patients may also present with cafe-au-lait macules. As you can see, these are these tiny papules on the eyelids, flesh-colored mucosal neuromas on the tongue, oral cavity, inner lip, and the thick lips, which could also have the mucosal neuromas. Rarely you might have these conditions called dermal hypernuria, which is a proliferation of the cutaneous nerves, which might manifest as these little lesions, and sclerotic fibromas, which were usually on the plantar surfaces. And these were found in a big cohort of 11 family members, and it was considered that it could be added to these cutaneous manifestations of MEN2A. All right, acromegaly. Most of us are pretty well versed on paper when we read about acromegaly. We all know that it causes macrocyclia, thickened lips, acanthosis nigricans, increased sweating, large tongue, coarse facial features, hypertrichosis, gingival hyperplasia, which causes widening of the or increased spaces between the teeth, nail changes, thickened fingers, and there's much less known condition called cutis verticis gyrata. Even with all these other known manifestations, the average time from onset of symptoms to diagnosis for acromegaly is actually 10 years. So if we could just pick up earlier on some of these signs, it would be extremely helpful for the patient for their future morbidity and sometimes mortality. So what is cutis? I chose to focus more on this because I think we know the rest of the manifestations better. CVG, or cutis verticis gyrata, is hypertrophy and coarse folding of the scalp skin with alternating crests and deep grooves almost resembling the brain, like a cerebriform of cerebral gyri. Acromegaly is one of the secondary causes. They're primary causes as well. There could be multiple other causes for this condition: scalp diseases, genetic syndromes, testosterone use sometimes. The folds in CVG are soft and spongy and not easily flattened by traction or pressure. So you can't just kind of smoothen these folds out. The areas of scalp affected in acromegaly could be any from frontal, frontoparietal, parieto-occipital, and they eventually might affect the glabella and nasal bridge. The pathology, the pathogenesis, is usually because of the increased stimulation of the dermal fibroblasts by the action of growth hormone and IGF-1. The collagen deposition is prolonged, progressive. It's usually a benign condition, but because of the deep folds, these can actually get infected and cause skin infections, significant skin infection, and also it might be more of an aesthetic issue. Awareness of this condition may allow for early diagnosis and treatment of acromegaly, which is the main focus of knowing this condition. Now we go to a more dramatic presentation. I'll give you just a minute, just a second to look at this before I go to the diagnosis. Yep. So this is necrolytic migratory erythema, which is a key skin manifestation of glucagonoma, which is excessive secretion of glucagon, a pancreatic alpha cell tumor, and occurs in nearly all patients during the course of the disease. It actually could be the presenting symptom in 70% and can be misdiagnosed due to its rarity. It's characterized by erythema that progresses to form painful pruritic bullae and vesicles, which progress over 7 to 14 days, a week to 2 weeks, and they might rupture and cause hyperpigmentation and crusting, much like some of these lesions. They might form in the groin, extremities, thighs, buttocks, perineum. Some of these are demonstrated here and can be extremely pruritic and painful. The perioral area may also be affected, and superinfections are common. In areas of constant friction, they become thickened, lichenified, and might resemble psoriasis. And they can also occur in areas of trauma, which is the Kibner phenomena, or Kibnerization. Angular cheilitis, stomatitis are also concurrent known manifestations of glucagonoma. 50% of patients die within 5 years of diagnosis of this condition, but early diagnosis can help reduce morbidity and mortality. All right. So focus on this fourth digit. These are more familiar. The one on the right is less common. No, that's elephantiasis, the one on the right. On the left, we'll come to it in just a bit. And some dramatic hand changes, which are seen in Graves' disease. So hyperhidrosis is a pretty common manifestation, increased sweating, sweaty palms, we all know that, but onycholysis, or plumber's nails, thyroid acropathy, pretibial myxedema, which can also occur, the myxedema can also occur in hypothyroidism. Thyroid dermopathy, which in its severe form is elephantiasis, and palmar telangiectasia are common in Graves' disease. Pretibio myxedema lesions are bilateral, firm, non-pitting, asymmetrical plaques or nodules. The hair follicles are pretty prominent, giving them a pudy-orange kind of an appearance, an orange-like textured skin. The elephantiasis form, in that form, the lesions may coalesce and give an enlarged versiform appearance to the entire extremity. These could be quite disfiguring. Hyperhidrosis and hypertrichosis might be present. The lesions characteristically appear on the shins, lateral or anterior aspects of the legs, but they can occur on thighs, shoulders, hands, pretty much any other skin surface as well. They can also occur at areas of recent or prior trauma, donor sites, and usually are pinkish, brownish color. Thyroid acromegaly, it affects less than 1% of Graves' disease patients, but can be pretty dramatic, as you can see in these pictures. The prevalence is higher in folks in their 50s, women more than men, and occurs as digital clubbing with diaphyseal proliferation, sometimes some subluxation with disruption of the terminal phalanx at times. It is very strongly associated with Graves' orbitopathy and with dermopathy, and smoking is a risk factor. We don't really know if getting folks euthyroid helps it. And onycholysis is a condition where your distal nail separates from the nail bed. As such, as you can see in this picture, it appears more white where there is separation from the nail bed, and it occurs more when they are hyperthyroid, so euthyroid are less likely. And you can see it in the 4th digit most often. Hashimoto's thyroiditis and thyroiditis with hypothyroidism can occur in its most severe form as myxedema. You can see macroglossia, broadening of the, which is the macroglossia is the large tongue, broadening of the nose, lip thickening, loss of hair, dry skin, generalized red rash, erythematous rash. There's interesting rash, erythema annulare centrifugum, and loss of lateral eyebrows. On the left, you see there's advancing skin lesion with central clearing. These usually have an indurated serpeginiform kind of a advancing lesion, which is 6 to 8 millimeters in thickness, and this clear in the center. And this is a picture of a myxedematous lady with thickened skin. I guess we all know this. This is pretty well known again, dorsal hump, buffalo hump, your violaceous striae, acanthosis nigricans, and this is the steroidogenic acne or eruptions from Cushing syndrome. The moon facies, bruising, delayed wound healing, the striae like you saw, all of these are usual manifestations of Cushing's. We will skip through this. We have a lot to cover, so the stuff that you already are familiar with, we'll skip quickly. Okay, so what is this? As you can see, there's angular cheilitis and pretty dramatic changes in the nails. These are manifestations of APS or autoimmune polyglandular syndrome. We'll briefly go over what each type is. It is a heterogeneous group of immune-mediated disorders characterized by insufficiency of at least 2 endocrine organs. Type 1 is autosomal recessive, mostly presents in childhood between 3 to 5 years of age and sometimes in early adolescence. And 2 of 3 features are usually present. The chronic cutaneous candidiasis, acquired hypoparathyroidism, and primary adrenal insufficiency. APS type 2 is more polygenic, autosomal dominant, and manifests in the 3rd or 4th decade of life, characterized by adrenal insufficiency with thyroid or type 1 diabetes. Let's talk about APS 1. Chronic mucocutaneous candidiasis is observed in a majority of patients with this condition and typically presents prior to the associated endocrinological features. Persistent fungal infections of mucous membrane, skin, and nails occur. Oral candidiasis might occur. And usually peaks in incidence within the first 2 years of life. These can result in angular cheilitis, scalp infections, intertrigo, diaper rashes, perianal rashes, fungal infection of the nail beds, like you saw earlier, with discoloration, thickening, and paronychia, which is the inflammation of the nail bed. You can have other associated dermatological conditions with APS, which could be alopecia areata, which is localized loss of hair, and vitiligo, which is depigmentation because of the loss of the melanin, and it affects 30% to 10% of patients. And these two, the vitiligo and alopecia, are less frequent in APS 2 and 3. As you can see in this picture, this is pretty dramatic presentation of the vitiligo and some localized hair loss there. The hypoparathyroidism may have its own set of clinical skin findings. The skin is typically dry, scaly, hyperkeratotic, which is just thickened, and you might have opaque brittle nails with grooves, and again, the sparse hair. Addison's disease, this is primary adrenal insufficiency. You see most of the hyperpigmentation in this condition because of the melanocyte-stimulating hormone effects, hair hyperpigmentation, diffuse cutaneous pigmentation, mucosal hyperpigmentation, loss of axillary and pubic hair because of the adrenal being non-functional, longitudinal hyperpigmented nail bands, and vitiligo might be an associated finding. So these are the hyperpigmented hands compared to their family member. Primary hyperparathyroidism usually does not present with any dramatic, usually does not present with skin manifestations. When it does present with something, it's pretty dramatic. So benign nodular calcification, form of calcinosis cutis, may occur due to metastatic calcification in this condition. The skin lesions are characterized by indurated white papules or plaques located in the subcutaneous tissues, sometimes near the joints. And then you have this, which is the most extreme skin manifestation related to calciphylaxis due to calcification of blood vessels supplying the cutaneous tissues. Usually it occurs in your tertiary hyperparathyroidism, but can also occur in primary. It begins as mottled skin lesions, almost like livedo reticularis, becomes very painful, necrotic, and has this eschar kind of a presentation. These may progress to sepsis, have superimposed bacterial infection, and when it occurs in the terminal areas, such as digits, it could cause gangrene as one of the manifestations. There are several endocrine conditions that have androgen excess, and hirsutism and acne are the usual manifestations. It could be something as common as PCOS, or something more grave like an ovarian tumor. It can also be seen in congenital adrenal hyperplasia, Cushing's, exogenous androgens, acromegaly, and hyperlactin levels. Let's take a look at some of the hypoparathyroid skin manifestations. The skin, like I said, is often dry, scaly, puffy, hyperkeratotic with brittle nails that develop transverse ridges. The hair becomes coarse and sparse, and you could have eczematous dermatitis and maculopapular eruptions in this condition. Autoimmune hypoparathyroidism is often associated with your candidal infections. And in pseudo-hypoparathyroidism, or in pseudo-pseudo, which is where the paternal allele is responsible, you might have more dramatic presentations like your Albright's hereditary osteodystrophy, which consists of short stature, short neck, brachydactyly, especially shortening of the 4th and 5th metacarpals, and the presentation that you can see here. All right, let's move on to diabetes. Diabetes can be associated with skin manifestations in most everybody. It has a range of 30 to 90%, but most everybody, I would say, has some kind of manifestation in their lifetime. It could be the first sign of metabolic disturbance where it could lead to the diagnosis of diabetes. It could mean that the diabetes is suboptimally managed because certain microangiopathic complications may actually go along with the skin manifestations, or it could be a sign of a pre-diabetic state. Some skin manifestations are more common in type 1 versus and some are more in type 2. So necrobiosis lipoidica diabeticorum, diabetic bullae, vitiligo, and periungual telangiectasias are much more common in type 1. Type 2 usually is associated with generalized granuloma annulare, scleroderma diabeticorum, which is not to be confused with scleroderma, diabetic dermopathy, acanthosis nigricans, skin tags, or acrocodons, psoriasis, and yellow skin and nails. Even amongst these, some are specific markers, while some are non-specific markers. We will focus more on the specific markers, which is the necrobiosis lipoidica, which when it occurs in diabetes is diabeticorum, generalized granuloma annulare, acquired perforating dermatosis, the diabetic bullae, scleroderma, dermopathy, eruptive xanthomatosis, and the acanthosis nigricans. I think that got cut off there. So what's your diagnosis here? So this is necrobiosis lipoidica diabeticorum, which is a chronic, necrotizing, often disfiguring and disabling refractory skin disease seen in a small number of diabetes, less than 2%. These lesions begin as small, firm, red papules, and they evolve over time. They're usually well-demarcated annular plaques and have this atrophic yellowish center with some ectatic vessels on the outside. Usually diabetes precedes this manifestation. However, sometimes necrobiosis can develop concurrently with the diabetic condition, or diabetes may occur after the skin manifestation. They can be asymptomatic, or they could be painful and pruritic, especially when ulcerated. The sensation of the skin is often reduced, and that's because of the cutaneous nerve damage. Ulceration occurs in approximately 35% of these, either spontaneously or due to trauma, and these ulcerated lesions may progress to squamous cell carcinoma. Like mentioned earlier, it is more frequent in your type 1s, more common in women. Typical onset is third decade. If it occurs in other types, it's usually in the insulin dependent. So this is generalized granuloma annulare. There's 5 different variants of granuloma annulare where there's localized, subcutaneous, perforating, arcuate, but the generalized one is the one that's more commonly associated with diabetes. Its prevalence is lower under diabetes, but if you have it, then you're more likely. So 21% to 77% of patients with generalized GA actually have diabetes. They appear as multiple small, firm, skin-colored papules distributed over the extensor surfaces and the distal extremities, sun-exposed trunk, and they usually expand with central involution. And as you can see, this does not have your yellowish centers like the other one, the necrobiosis lipoidica. They're typically asymptomatic, but can also be itchy. No. Women more common than men, persistent and relapsing courses with poor long-term outcomes. And if you see a new case, you should screen them for diabetes. Diabetic bullae. This is rare, non-inflammatory, but these are tense, pretty big sometimes, painless bullae that develop abruptly on normal-appearing skin. They're typically present on the distal, lower extremities and less often involving the hand or forearm. They can occur during sleep and without any preceding trauma. And some of these have been known to rapidly evolve over minutes. They become flaccid, uncomfortable as they enlarge. They could be solitary, they could be multiple, usually filled with a clear, sterile, serous fluid, but they could be complicated by hemorrhage and infection. It's most often encountered in the setting of long-standing type 1 diabetes with complications such as neuropathy, nephropathy, or retinopathy. Rarely it can occur in type 2, more often in men in about 50 to 70 years of age. They usually heal pretty quickly, not quickly, but without treatment, about 2 weeks, 2 to 6 weeks. But if they get complicated by infection, they could lead to osteomyelitis, and especially if they occur on the extremities, might lead to amputation. There are some theories about preceding hypoglycemia as a inciting event for diabetic bullae. So appropriate regulation of blood glucose has been recommended to prevent eruptions. And treatment is focused mainly on skin protection and preventing secondary infections. It could be anywhere, but if it does occur in the limbs then and gets infected, it's likely to cause more problems. Diabetic scleroderma is a rare chronic connective tissue disorder, usually seen in type 2. It's thickening of the dermis, as you can see here, usually on the posterior neck, upper back, and shoulders, with some extension to the torso, face. Usually the acral areas are spared, so they don't, unlike scleroderma, which might affect your fingers or so. The skin is hard, thick, and indurated, and again has a pudy orange kind of a appearance. It occurs in 3 to 15% of diabetic patients and likely to develop in those with long-standing diabetes with poor glycemic control. Much more common in men. Although we don't know if strict glycemic control helps it, it definitely is something that we should aim for. It does. Yeah, it's pretty indurated and red. Acanthosis nigricans, I think you see this pretty often. Diffuse hyperpigmented light brown to black, velvety, verrucous thickening, usually seen in the flexural intertriginous areas, axilla, groin, sometimes, even the face, the dorsum of the hand, posterior neck. These are poorly marginated and cause accentuation of skin markings. They're asymptomatic, but could get infected, painful, and macerated. It is associated with type 2 diabetes, but pretty much any insulin-resistant syndrome. So PCOS, lipodystrophy, acromegaly, Cushing's, Addison's, thyroid diseases, or insulin resistance, like I said. It's chronic but reversible, so the focus should be on weight control, dietary restrictions, and making sure that you are optimally controlled with your glycemic control. Diabetic dermopathy, also called shin spots, or pigmented pretibial patches, are seen in about 50% of diabetic patients. They initially present as asymptomatic round, dull pink papules and occur on the pretibial skin, but also might occur at other sites. After a couple of weeks, they might evolve to form more atrophic brown scaly lesions, sometimes with some depressed hyperpigmented areas. Usually they occur in men more than 50 years of age. Again, long-standing diabetes, poor glycemic control puts you at a higher risk of having them, along with other complications of diabetes. The dermopathy can also precede the onset of diabetes. We don't know if the glycemic control correlates directly with it. If you have 4 or more shin spots, you definitely want to go ahead and evaluate for diabetes. For the skin lesion itself, really no medical intervention is needed, but management should address microangiopathic complications and other macrovascular disease as well because of their association with diabetic dermopathy. Pigmented purpura, which is kind of diabetic dermopathy, it coexists with it and occurs in about 50% of cases. It is a group of uncommon idiopathic skin condition causing patches of brownish orangish discoloration with some cayenne spots or cayenne pepper, like little dots on it. And these are non-blanching. They distribute over the lower extremities, especially the pretibial leg with some involvement of the ankles and dorsum of the feet, and precipitated by congestive heart failure. So usually they might just it's just the venous stasis there that causes some of this. In the absence of diabetic dermopathy, pigmented purpura by itself is not considered a marker of diabetes. APD, or acquired perforating dermatosis, is almost always associated with chronic renal failure, somebody with on hemodialysis, and these are highly pruritic lesions, and as you can see, they are keratotic, with the central umbilication with a keratin plug. The eruption is found primarily on the extremities and trunk, sometimes on the head, and usually are unresponsive to therapy. Dialysis does not improve the course of the disease, and you do want to avoid trauma to these areas. Eruptive xanthomatosis. These are not very common, but when present are pretty much pathognomonic of hypertriglyceridemia. They occur as multiple little yellow papules, 1 to 4 millimeters in diameter on the extremities, extensor surfaces, buttocks, and might arise because of, again, trauma, Keebner phenomena, or pressure points. They do have erythematous halos at their base and can be tender or pruritic. Almost a third of them have some serum lipoprotein abnormalities, and that's because of the lack of insulin or decreased insulin, which causes decreased clearance of the lipoproteins. As mentioned, insulin does play an important role in triglycerides and the lipoproteins, and the insulin deficient state is one of the reasons for these eruptive xanthomas. Recognizing these xanthomas may be an essential clue to deteriorating metabolic status. Early identification and treatment can prevent more complex conditions, atherosclerotic complications, and pancreatitis. These do resolve with control of your carbohydrate and lipid levels and metabolism. Let's go to some non-specific skin signs, skin tags. We do see these in a lot of our patients. They're present in about 3/4 of patients who do have the skin tags have frank diabetes, and more than 80% show some degree of impaired carbohydrate metabolism. Higher incidence is seen if you have more than, the carbohydrate metabolism is seen if you have more than 30 skin tags in this one particular study. And if women have inframammary skin tags, then they're at higher risk for diabetes. Yellow skin and nails, these are asymptomatic, benign, probably more often due to fungal infections. Generalized itchiness, dry skin is a feature of diabetes, but what's more specific is vulvar pruritus, and the poor circulation, poor microcirculation, and decreased hydration or hypohidrosis are the likely cause of generalized itching. Rubeosis faciae, or red face, is benign by itself, but could indicate microangiopathy secondary to suboptimal glycemic control. We should be evaluating for retinopathy in patients with this condition, and again, strict diabetes control is often helpful. Yeah, rosacea is more localized. You'll see a lot of the diabetes patients, they look just red all over. Yeah, yeah. Palmar erythema, this is a microvascular complication of both type 1 and type 2. It's often symmetric, asymptomatic on the thinner and hypothinner eminences. It is benign, but again, you want to go ahead and look for microvascular complications. And same with the nail bed erythema. Yes, it is commonly associated with that too. So, what are the skin manifestations of diabetic vascular disease? Some of these I'm actually going to run through because we do have a couple things we need to just go at the end too. So diabetes causes both large and small blood vessel disease. So if you have atherosclerosis of the bigger vessels, you might, and so peripheral arterial disease, you would have shiny, hairless, atrophic skin, cold toes, dystrophic nails, pallor when you elevate the foot, and mottling on dependence. Usually this poor blood supply leads to wound healing issues and recurrent cutaneous infections, and increases the risk of gangrene and amputation. So if you have a person who has, say, a gentleman who has hair only up to the calf and decreased hair further down, you want to be looking for vascular issues. The skin manifestations of diabetic neuropathy could be hypohidrosis and anhidrosis because of autonomic neuropathy. The change in perspiration could cause dry skin, fissuring of the skin, which makes it easy for the pathogens to enter and cause infections. You can have increased skin temperatures and redness from vascular dilatation, and loss of cutaneous sensation just puts you at a higher risk of having ulcers and injuries, impaired healing. There are other specific conditions of the hands, limited joint mobility, LJM, thick dorsal hand skin and finger pebbles, and Dupuytren's contracture, which are all dermatological manifestations in diabetes patients. The limited joint mobility, also called as diabetic chiroarthropathy, is actually a pretty common finding in diabetes and is a warning sign of a fourfold increase in microvascular disease. It presents with restricted movement of your metacarpophalangeal, interphalangeal joints, usually begins with the fifth finger and spreads radially, and it's caused because of thickening of the periarticular connective tissues. Long-term diabetic control does improve your limited joint mobility, so that should be the goal.
That also, like,
Yeah, you know, so your frozen shoulder and other, that's also a spectrum of that. It's not a skin manifestation, so, but yes, it's an extension of that. Dupuytren's contracture, remember to examine your patient's palms. It is a chronic progressive fibroproliferative disorder because of thickening of the palmar fascia, with nodules in the ventral hand, which evolves to flexion contractures, can cause limitation of their activity levels. It affects approximately 20% of diabetic patients, and the prevalence increases with age. About 13 to 40% of patients have Dupuytren's contracture in diabetic patients, and we don't really know the exact pathogenesis, but it's probably unrelated to the glycemic control. Here's a more close-up picture. So these are some other manifestations: digital sclerosis, thickening of the digits, thickened hand skin. In general, diabetes patients seem to have thicker skin. They have thick, waxy skin. They might have, the sclerodema and greater skin thickness than most other individuals. You can just have concurrent other conditions: vitiligo, psoriasis, bacterial infections, fungal infections that might be seen in diabetic patients. There should be a high suspicion for some of these rare cutaneous infections, which are the mucormycosis, necrotizing fasciitis, and malignant otitis externa, which are all likely to be potentially fatal. Treatment-related skin issues can also occur: lipoatrophy and lipohypertrophy at site of insulin injections, and hence the need to keep moving your sites on a regular basis. Drug-related reactions: metformin by itself, it can induce a psoriasiform drug eruption. Erythema multiforme, vasculitis, urticaria are just some of the few manifestations that can be associated with diabetes. Yes, I mean, all the medications, yeah. Moving on to this interesting feature, spider angiomas. This is a vascular lesion which is characterized by dilatation of the end vasculature just underneath the skin surface. And just like the name suggests, it looks like a spider. It's got this central spot with reddish extensions that radiate out like a spider's web. It could be multiple, it could be single. They're painless, and they do blanch. They are benign, but can suggest an underlying systemic condition such as cirrhosis and thyroid conditions such as thyrotoxicosis. Solitary spider angiomas can be normally present in individuals, usually less than 3. They can also occur in physiological conditions, mostly hyperestrogenic state, such as pregnancy or severe malnutrition. When you have multiple spider angiomas, you need to be looking for chronic liver disease. It has a specificity of 95%. Prevalence is highest among patients with cirrhosis, alcoholic hepatitis, and hepatopulmonary syndrome, with the higher risk of mortality in patients with alcoholic liver disease. They also could indicate that you have portal hypertension. It just indicates the degree of your liver involvement, the hepatic fibrosis, and hence the esophageal varices. The reported prevalence of spider angiomas in cirrhosis is about 33%. So, coming to our cases. So the first patient, he presented with pretty dramatic prolactin levels in the thousands. On presentation, his calcium level was actually normal, 9.9. But on physical exam, the cholangiomas were very evident. And actually, I have to thank Dr. Winters, who showed me my first cholangionoma when I was a fellow. So that's, definitely stuck. So I went back and did some searching, and through his prior labs, all of them showed some minimal elevation of calcium level, 10.1, 10.2, which basically led to further workup and a diagnosis of primary hyperparathyroidism, which led to genetic testing and confirmed MEN1. So he had no history to go by, but obviously there was something probably going on the paternal side, or maybe not, but it would definitely help him in the future for genetic counseling. The second patient I thought was interesting. Not very high BMI, but a host of medical issues. Diabetes with multiple complications. He had an osteoporotic fracture, and these characteristic findings on the scalp. This is not my case, but this is an actual case presentation published. And sometimes cutis versus gyrata can actually be, there have been some cases where it was the presenting symptom. So a high suspicion along with your other clinical findings is essential for further testing. So this patient did have acromegaly, which was treated appropriately. And the last patient, this was actually my patient. He was very well-controlled diabetic, but a BMI of 45, and had these obvious spider angiomas and some palmar erythema, not very distinctive, but it was there. And I ended up ordering a fiber scan, and she had cirrhosis. So she's now under the care of a gastroenterologist for further management. And as we all know, fatty liver disease is surpassing every other cause for cirrhosis of the liver, so this should definitely be on our watch list. That's all I have. Thank you all very much. I know that we did go pretty fast, but I wanted to leave a little bit of time if you had any questions in today's event code. Thank you.
Very good for the panel. So I was thinking you add the celiac as group.
The dermatitis herpetiformis. Yes, and I have actually done a whole entire talk of celiac disease and the endocrinologist in the past.
Sometimes they show that in.
Right. Yes, I could have. It's a little bit more contrived because it's celiac disease. That's the first manifestation, and then celiac can concurrently occur with your primary hypothyroidism and other autoimmune conditions, but it's not a primary. And like I said, there's actually a few conditions that I was not able to include because I didn't want to overwhelm and exceed the time. I don't think I see any in the chat either. Yes. The malar rash. With what?
Lupus.
Within the fingernails? I don't know. I mean, I would defer that to the rheumatologist mostly because they see mostly the lupus patients, but I don't know of lupus in particular. Now, psoriasis, what's that?
They can have secondary there.
Yeah, they can definitely have Raynaud's. Psoriasis can occur concurrently with a lot of these conditions, and pitted nails, yellowish and pitting nails is a feature of that. So you could have these autoimmune conditions all coexist, and you could have that nail manifestation along with it. Yes.
If there are lesions, two.
Two
lesions.
or.
Does that mean like angiocarcinoma?
Yeah.
Just two of the cholangiomas?
No. Two of the kinds, so angiofibromas, because cholangiomas are multiple. They never occur solitary. They're multiple, they're spread over all over. Yes,
You
and
can easily miss it because
yeah,
it's very fleshy.
right, they're always almost flesh-colored papules, but it's hard to miss. If you want to go back, I can go back to the slide. But once you've seen that, you should never miss it. They're there. If you see them, you gotta have a suspicion. Even if your calcium levels are normal at that time, you should be testing these folks.
And then, like, so let's say somebody has a thyroid lesion, and then they have parathyroid and the pancreas. Those are the three.
Right. Two out of those. Yeah, you have those.
So then the skin lesion.
I would say I'm not sure if they're replacing, but like I said, they can often occur even before some of these other manifestations might present. So that should be an indicator for you to probably even proceed with genetic testing. Yeah. So I have a question from Mr. Kotwal here. Do the dermatologists refer cases to endocrinologists or the other way around? We don't usually get any referrals from dermatologists, but like I said, as an endocrinologist, we are expected to be. We kind of get everything that people don't know what to do. So, we don't know what to do. Can you just take care of this patient? He's tired. The fatigue could be from just about a million different things. So most of the times, I would say the clinical manifestations are by the way kind of things that we pick. We don't get those referred to us to see, is this endocrine related because I see a dermatological manifestation. Do we refer our cases to dermatologists? It depends on the severity of some of these. If the necrolytis, like I said, some of these conditions can actually regress after appropriate endocrine treatment. So diagnosing that and then if needed, referring to the dermatologist might be the way to go. If that answers your question. Do I even have this on for them?
Thanks.
No, I can't. Okay. All right. Okay, he did respond. All right. I can look at the chat, yes. I don't know where the video thing is if I'm seeing it.
Yeah, you're right.
Okay. Thank you. I hope you all learned something. I think it's always
Repetition.
Yeah. Reinforcement, and again, having a really high clinical suspicion. If you think something's wrong, please go ahead and pursue it. Don't just let it go. If you think that, I think this individual's rings too tight, and ask them questions that might lead to acromegaly. Acromegaly is one of the, I think, main endocrine conditions which has dramatic presentation and yet gets very late diagnosis because they're gradual. So you want to ask them to show their picture from their driver's license 5 years ago or in their phone 10 years ago. Ask them if a friend noticed they look different. And usually these patients do have symptoms. They just don't know, they just don't get picked up. So. Yep, you look at all these different things, you really can learn a lot. The skin is indeed a window to the inside, so nothing beats a physical exam. So examine all of patients, especially on their first visit, and then if needed, follow-ups. You can do focus exams. Thank you all very much.
Go ahead and stop here.
Stop share.
Or close it, whatever. Yeah. Great, Swapna.
Thank you.